Welcome to Derm Drop, your TLDR in dermatology. I'm your host, David Sider, and episode 4 begins with the suggestion that you might want to screen for HIV when you have a young male patient with shingles. That's because herpes zoster was the presenting symptom that led to HIV diagnosis in over 1/4 of the patients in a retrospective study of 45 cases of zoster diagnosed in patients with HIV between January 2015 and September 2024, conducted by researchers in the dermatology and infectiology departments at Hassan II University Hospital in Morocco, and published in the March 1st, 2025 issue of the International Journal of STD and AIDS. The patients in that study were predominantly male. It was an 8-to-1 ratio, with a mean age of about 36 years. Without antiretroviral therapy, the risk of developing herpes zoster in this population is 10 to 30 times higher than the general population. A low CD4 count is a strong predictor of zoster. Even on antiretroviral therapy, the risk is 3 times higher. In fact, of the 21 patients in the study who were on antiretroviral therapy, 6 developed herpes zoster shortly after antiretroviral therapy was initiated, suggesting an immune reconstitution inflammatory syndrome, or IRIS. IRIS is often seen in HIV patients when antiretroviral therapy leads to reduced immunosuppression and a paradoxical worsening of a pre-existing infection as the immune system mounts a response. In dermatology, we have an opportunity to make a meaningful difference by recognizing herpes zoster as a sentinel sign of undiagnosed HIV and providing screening when indicated, especially in younger patients who present with herpes zoster without a known underlying immunosuppressive condition or other risk factors. That's because early HIV detection leads to timely initiation of antiretroviral therapy, which reduces viral transmission, opportunistic infections, and disease progression. In other more colloquial words, the early derm gets the worm. So let's go viral. Our second quick pick of episode 4 starts with a question of what you get a guy with solid facial edema. You get him a Dupixent prescription, of course. It's the gift that keeps on giving. Dr. Luke Johnson, MD, co-host of the popular Dermosphere podcast and associate professor in the Department of Dermatology at the University of Utah, along with Dr. Nicole Hughes, MD, in the Department of Family and Preventative Medicine, and 2 students in the Spencer Fox Eccles School of Medicine, Annabelle Huntsman and Zach Ney, did just that and shared the outcome in JAD case reports on February 16th, 2025. In their case, a 16-year-old male had facial swelling, induration, and erythema for 18 months that did not adequately respond to 2 courses of isotretinoin, which was over 15 months combined of isotretinoin, or prednisone, doxycycline, cetirizine, or a gluten and dairy-free diet. Also known as Morbihan disease, solid facial edema was first described in 1957 by French dermatologist Robert Dagos, thanks DermNet, and is generally considered a rare, refractory, eventually permanent lymphadematous variant of rosacea, in which chronic inflammation leads to loss of lymphatic vessel wall integrity and diminished drainage, resulting in firm edema in the upper face. But since solid facial edema can present in the absence of other signs and symptoms of rosacea, some do consider it a separate entity. After developing eosinophilic esophagitis in the context of other atopic comorbidities, the patient was prescribed dupilumab, and within 1 month, he reported near total resolution of his solid facial edema. 3 months after starting Dupi, he discontinued isotretinoin, and some swelling did recur, but remained satisfactorily controlled on monotherapy, suggesting a role for Th2 inflammation in the pathophysiology of solid facial edema, in which activation of eosinophils Mast cells and basophils, along with recruitment of macrophages, leads to increased fibrinogen production, endothelial barrier dysfunction, and local edema. And that highlights one of the coolest things about Dupy. In addition to relieving a lot of human suffering, it has illuminated previously unknown pathogenic pathways in dermatology. So thank you, Sanofi and Regeneron. Interestingly, while variable results have been achieved with oral ketotifen, a dual-action antihistamine/mast cell stabilizer only available in the U.S. via compounding, clofazimine, thalidomide, excision, CO2 laser, radiotherapy, and massage, the authors posit that dupilumab and isotretinoin may have a synergistic effect by managing both immune-driven and sebum-related contributors to solid facial edema. Our third quick pick poses the question, do tattoos cause cancer? Now, I'm not calling the derm cops on the tattoo party just yet, especially after we rained on the tanning bed parade, but a cohort study of 2,367 randomly selected twins and a case control study of 316 twins in the Danish Cancer Registry, published in the January 15th, 2025 issue of BMC Public Health, found 1.33 to 1.62 higher rates of skin cancer with a 95% confidence interval among the tattooed twins compared to their uninked counterparts in the case control design, and 3.91 higher rates with a 95% confidence interval in the cohort studies design. The authors applied both individual and matched study designs to the data to control confounders, which included other health-related lifestyle factors associated with tattoos, such as smoking, drinking, and increased sun exposure. They also point out that tattoo ink may not cause cancer, but instead lead to later detection and thus more severe cancer. But when tattoos were larger than the palm of a hand, the skin cancer hazard ratio went up to 2.37, and for lymphoma, it was 2.73, also 95% confidence interval. So yeah, probably it's a risk factor, but how? Tattoo ink leaves the skin through the blood and travels to the lymph nodes where it is recognized as foreign, triggering chronic inflammation and increasing the risk of abnormal cell proliferation. So, too late. Your ex's name is already wrapped around your biceps. What now? Well, laser tattoo removal breaks pigment into smaller particles, allowing for even greater migration potential. So, have you and your ex thought about getting back together? Of course, more studies are needed, but be aware and be prepared to provide your tattoo-curious patients with evidence-based answers. Our last quick pick of this episode is about the association of hearing loss with vitiligo. Yes, you heard that right. Almost 40% of vitiligo patients have sensorineural hearing loss, according to a systematic review and meta-analysis published in the July 2023 issue of the Journal of International Advanced Otology. Another systematic review and meta-analysis of 14 case control studies of 938 patients with vitiligo, published in the December 2021 issue of the Journal of the American Academy of Dermatology, found an odds ratio of 6.02, 95% confidence interval, even after adjusting for study quality and publication bias. The odds ratios remain significant, 5.30 and 3.45 respectively, both with 95% confidence intervals. Why? Because the inner ear contains melanocytes. What are melanocytes doing in the ear? They regulate potassium concentration in the cochlea, which is required for proper functioning of the hair cells, which translate sound vibrations into neural signals. Melanocytes also support normal hearing by protecting hair cells from oxidative damage. So when autoreactive CD8 positive T cells on the hunt for melanocytes get pulled by integrins and adhesion molecules molecules into the cochlea, patients lose sound in addition to color. That's a double whammy. Luckily, in most cases, the hearing loss involves the higher frequencies and is subclinical. Even luckier, systemic vitiligo therapies in the form of JAK inhibitors are just around the corner. And Insight did a sensorineural hearing loss post hoc subanalysis on their JAK1 inhibitor povorcitinib's phase 2 data and found hearing improvements in patients who received the drug. By the way, povorcitinib is also in phase 3 trials for hidradenitis suppurativa. Interestingly, the patients in their study who had sensorineural hearing loss had less extensive vitiligo than their counterparts without sensorineural hearing loss. In other words, vitiligo-associated hearing loss does not correlate with disease severity. So consider referring your vitiligo patients to audiology for routine hearing assessments and early recognition and management of sensorineural hearing loss. And if you find yourself having to raise the volume in your vitiligo follow-ups, get a systemic on board. If you want links to these articles, please go to my LinkedIn. It's David Seiter, Seiter. Hit the thumbs up, the likes, the subscribes, all the things, and I'll see you next time. Thanks for tuning in.